This week's lecture, we're going to talk briefly about drugs for weight loss. Here in the United States, the issue of obesity kills nearly 300,000 Americans each year from obesity-associated illnesses. And you can see that the risk for morbidity can be increased when patients have these associated diseases: hypertension, coronary artery disease, stroke, type 2 diabetes, gallbladder disease, kidney stones, osteoarthritis, sleep apnea, dementia, and certain cancers. Obesity is also linked to menstrual irregularities like also amenorrhea and polycystic ovarian syndrome. We also see in pregnancy that obesity increases the risk for morbidity and mortality for both mother and child, and for young men, it can reduce the quality and the quantity of their sperm. Pediatric obesity is also of special concern. We know that 1/3 of American children and adolescents are overweight or considered obese. And though it is a chronic disease like hypertension and diabetes, and though we have extensive research regarding obesity, we still don't fully understand the underlying causes. But we do know that there are contributing factors like genetics, metabolism, also our ability to regulate our appetite. We can consider environmental factors, psychosocial, and cultural factors as well. We do continue to use the body mass index, or BMI, to help us understand the correlation between the patient's weight and height, to give us a numeric value that will tell us where our patients lie. And if their BMI is less than 18.5, they're considered underweight. And you can see a normal weight BMI would be 18.5 to 24.9, and it gets progressively higher. 40 or greater is considered morbidly obese, and you can follow along on the chart. And BMI is calculated by figuring out the weight in pounds, multiplying that by 703, and dividing that by the height in inches squared. You can also see in the metric system as well, here in the schematic, what the formula is. Now, according to the federal guidelines, a BMI of 30 or more is considered obese. And there are associations between your BMI and your health risk, but they don't always apply to older adults, growing children, or women who are pregnant or lactating. So these are just guidelines, but it doesn't cover the entire lifespan. We also need to think about competitive athletes, bodybuilders, and those that have a higher ratio of muscle rather than fat. So because this is only calculating weight and not body fat. But waist circumference is another indicator that we can use of abdominal fat content, and independently we can use this as a risk factor for obesity related diseases as well. We also can think about in terms of the waist circumference, this accumulation of fat in this upper torso area and along the abdominal cavity. The larger that area is, you have a greater risk for health concerns than the accumulation of fat in perhaps the lower part of your body, like your hips and your thighs. And so those patients with too much abdominal fat are at an increased risk for insulin resistance, diabetes, hypertension, coronary artery diseases like atherosclerosis. They also have an increased risk for ischemic stroke and dementia. And so this fat distribution is estimated simply by looking in the mirror and looking at the body shape. And what the book says is that an apple shape indicates that there's too much abdominal fat. A pear shape indicates that the fats are located primarily on the hips and the thighs, so there's a lower risk there. But we can also use a measurement of waist circumference, and this provides a quantitative estimate of abdominal fat. So a waist circumference that exceeds 40 inches in a man or 35 inches in a woman signifies an increased risk for disease. And for people between BMIs of 25 and 34.9, this is true. So weight circumference outside those ranges, it's a little bit harder to use this as an independent metric. We also need to consider just the risk status of our patient. And this is determined not just by BMI or weight circumference, but we also need to see what is actually in the here and now. Is there a presence of weight-related diseases that they already have, or cardiovascular risk factors? And so looking at their whole health profile is going to help you to understand what the risk is for mortality and morbidity due to obesity. And so thinking about what are cardiovascular risk factors: smoking, hypertension, high levels of LDL, low levels of HDL, perhaps you have a high fasting glucose or family history of these things, maybe physical inactivity, advancing age. Also, as the BMI gets larger, your health risk also gets larger as well. And this is increased if you have excessive weight circumference on top of that. So these risks just compound. However, you can also use the multi-ethnic study of atherosclerosis calculator, or also called the MESA calculator. And this puts into perspective more of a culturally appropriate risk calculator. And so again, it's the MESA, multi-ethnic study of atherosclerosis calculator. And you can find that online. It's very helpful to use with patients. So what are the treatment modalities? Obviously, we want to start with lifestyle changes and therapy that focuses on improving their overall health risks and the perhaps preventative actions. So we think about first caloric restriction, physical activity, behavioral therapy, then drug therapy, and then surgery. So starting with caloric restriction, it is thought that a reduced calorie diet is central to a weight loss program, and you want to do this by balancing and by emphasizing portion control. You want to educate your patients on diet, but also you want to educate them on exercise, and not just cardiovascular exercise, but also weight training management as well. Behavioral modification is directed at modifying their eating and exercise habits, so it's reinforcing the first two. Self-monitoring of eating and exercise habits is going to be essential for your patient, so it needs to be mutually agreed upon, and they have to be willing to do these. And fortunately, we do have tools like MyFitnessPal and Choose My Plate to help with these modifying behaviors, but also perhaps getting professional behavior therapy is another tool that you can implement. So once you've exhausted these three, then you can move on to talking about drug therapy. And research does demonstrate that the addition of weight loss drugs to an obesity management treatment program promotes greater success than just lifestyle management alone. And over the last few years, we have seen new drugs for obesity management coming out, and new versions of drugs and new doses of these drugs. And they have been helping many people lose weight. Most of the drugs prior to this, drug therapy has been modest, but now we are seeing that patients are able to lose a higher range of weight on drug therapy. And the duration of therapy is going to depend on what drug you select, what class, but also what other lifestyle modifications are they making, and what else are they contributing to their weight loss management program other than the drug therapy alone. In any case, you would not want to continue drug therapy indefinitely. These drugs are not approved for long-term use. And not everyone responds to the drug, so a regular assessment is still required. Someone that may lose 4 pounds on a certain treatment may not lose the same amount as someone else that may have lost 20 pounds during the same duration of time. So you still need to think about how patients are responding. Also, patient adherence to the weight loss plan is something that also needs to be evaluated and considered what is appropriate with the drug that you selected for this. And for patients who don't respond, ongoing assessment needs to show that either you've tried a drug and now you're moving on to a different dose, or you're trying another drug class completely. Sometimes insurance companies will not pay for the drug of choice that your patient wants, so you do want to perhaps trial some other drug therapies, but most of the times you still need to go through the other modifications of lifestyle. But for the patients that actually have a positive response to drug therapy, ongoing assessment needs to show that the drug is helping them effectively to maintain weight loss also, and that the serious adverse effects are absent. Otherwise, even though they're losing weight but they have adverse effects, they need to be taken off the drug therapy. Bariatric surgery is still something that can be considered. Surgical procedures do produce a significant amount of weight loss, and we know that the two most common are the Roux-en-Y procedure and also the laparoscopic implantation of a gastric band. So these are both considered gastric bypass surgeries. They're pretty effective in reducing the volume of the overall stomach. And within 6 months to a year, patients actually will notice up to 110 to 220 pound weight loss. So obviously these surgeries are for patients that need to lose a considerable amount of weight. The algorithm that your textbook shows here is from the American Association of Clinical Endocrinologists, as well as the American College of Endocrinology. And this is part of their comprehensive clinical practice guideline on how to treat patients with obesity. And they're first asking you to consider what their BMI is. And if it is 25 or more, then you want to say, okay, in the first stage, we want to exhaust lifestyle therapy before moving on to a progressive pharmacologic therapy. So in stage 0, you've tried lifestyle therapy. You might want to consider drug therapy if this is not effective to meet the goal. In stage 1, you're considering, is the BMI over 27 or between 25 and 26? And so if it's over 27, you still want to provide lifestyle therapy, but you could consider drug therapy at this point. Between the range of 25 to 26, you still want to progress to lifestyle therapy first and then consider drug therapy if this is not working. In stage 2, you can consider, if a patient is over BMI of 27, within the range to 27 to 34, drug therapy can be considered with lifestyle therapy, and anything over 35, lifestyle therapy, drug therapy, but also you might want to consider bariatric surgery. Again, this is for patients that need to lose about 100 pounds or more of weight. Here on this chart, you can see that there are a variety of different medications, and their ability to promote weight loss differ in some ways. And this chart will show you the different preparations. Some of them are tablets, some of them are immediate release. The GLPs, which most of us are familiar with, we hear lots of commercials, there's lots of talk in the media, glucagon-like peptide 1 agonists. Those are prepared in multi-dose pens, and then we have some combination products as well that you can see here. Here's another chart that I think is really helpful from your book, and it's going through the pharmacokinetics, and you can see the metabolic pathways and how the patient would eliminate this product. So it is separated again under drug class and the drug. So let's start looking at some of the weight loss drugs here. In this table, you can see that there are different classifications and a variety of drugs that work on the body differently to help lose weight. And orlistat is a medication that has been approved for obese patients over 12 years old. And it's a little bit different than some weight loss drugs because it's not working on the brain here to lessen someone's appetite. It's actually working on fat absorption itself directly in the GI system. So orlistat is going to reduce how much fat your GI system can absorb. So specifically, this drug is acting in the stomach and in the small intestines and causes an irreversible inhibition of gastric and pancreatic lipases. Enzymes, remembering that these enzymes will actually break down our triglycerides into monoglycerides and break them down further into free fatty acids. But if triglycerides are not broken down, then they can't be absorbed. So at the level of the intestines and the stomach, we're blocking that inhibition of, again, pancreatic lipase. Without the lipase, we can't get triglycerides to break down into free fatty acids. With patients that are on orlistat, the absorption of dietary fat is actually reduced by about 30%. And so if they are going to do this, they also have to have a reduction in calories of about 30%, coming from fat. However, you have to be very patient with this drug. In recent clinical trials, it has taken most patients about 2 years to lose 19 pounds. That's about 10 pounds in their first year. So that's quite a long time to be on a medication to lose 19 pounds. However, it is still 19 pounds, so it is a good start. Additionally, you still need to think about reducing total cholesterol and helping your patient raise their HDL cholesterol as well, reducing fasting blood glucose and reducing their blood pressure. This medication is not going to affect those things. Because most of the mechanism of action is undergoing within the GI system, usually GI effects are common. Approximately 20 to 30% of patients will experience some type of oily rectal leakage, flatulence, fecal urgency, and fatty or oily stools. This is how the body is eliminating what cannot be broken down into free fatty acids. Another 10% will experience defecation and fecal incontinence. So this drug probably by now is not sounding very great to your patients. Dosing with psyllium like a Metamucil or a bulk forming laxative can help reduce the GI effects because it's bulking up the loose stool. This medication has also been shown to be associated with severe liver damage, rare cases, however, it's something to think about. And how would you note these signs and symptoms in your patient? You're looking for things like pruritus, vomiting, jaundice, anorexia, fatigue, if they have dark urine or light colored stools. They have to be stopped immediately until all liver injury has been ruled out. As soon as you experience any of these signs and symptoms, or your patient does, rather. Other than that, there's also rare associations with acute pancreatitis and kidney stones, but we don't really understand what the pathway is or what the causal relationship for that is. But we have noticed that cholelithiasis can occur on this drug. Contraindications. Anybody that has a malabsorption syndrome or they already have cholestasis, you would not want to prescribe this medication. In terms of drug or nutrient interactions, if we reduce fat absorption of the fat that we're trying to get rid of, we're actually also reducing fat-soluble vitamins like ADEK, vitamins A, D, E, and K. So vitamin K deficiency can intensify certain medications. If we don't have enough vitamin K, we're intensifying warfarin, which is an anticoagulant. And if patients are taking warfarin, we want to make sure that we're monitoring carefully, but now extra carefully because they might have vitamin K deficiency or depletion. So in order to avoid this, a patient that is prescribed orlistat not only needs psyllium or metamucil to combat the loose or runny stools, but also they may need to have a daily multivitamin supplement as well. And you want to tell them to take this about 2 hours before or 2 hours after taking orlistat. Leucovorin is a serotonin receptor agonist selectively for type 2C serotonin, and it helps to produce weight loss by telling the patient that they are full. It suppresses appetite and creates a sense of satiety by activating the hypothalamic and mesolimbic pathways that control appetite, and these pathways are located in our brain. Additionally, we have noticed that it reduces weight, circumference, fasting glucose, insulin, total cholesterol, LDL cholesterol, and triglycerides as well. So it does give additional benefits. Unfortunately, there are adverse effects that patients may experience, like headaches, back pain, a decrease in lymphocyte production, and upper respiratory infection. About 30% of patients with diabetes will also experience hypoglycemia. Now, there are some less common but more serious side effects like cognitive impairment, psychiatric disorders, priapism, pulmonary hypertension, valvular heart disease, and blood dyscrasias. And this is when there is a disruption in production of red blood cells, white blood cells, and platelets. Also, this drug is classified as a Scheduled IV drug under the Controlled Substance Act. So we know that this drug has the potential for abuse. In terms of drug interactions, because this drug is an inhibitor of the CYP2D6 isoenzyme, then if you're giving it with a substrate, then the drug is not going to be metabolized correctly. The serum levels of the substrate are going to be increased. So in order to decrease the risk for toxicity, if you have to prescribe both drugs, then the substrate needs to be prescribed at the lower dose, not leucovorin, which is the inhibitor. There's also a risk for serotonin syndrome, and this is associated with serotonergic drugs. Whenever there is a serotonergic drug, such as leucovorin, and it's given with another drug that is serotonergic, then the risk obviously is going to increase. And though we don't have enough studies to really evaluate the effects specifically, we do know that we need to prescribe with extreme caution and close monitoring for a different variety of drugs. You can see here on the slides SSRIs, MAO inhibitors being some of them, St. John wort, triptans, and there's a couple more here listed. The next group of drugs are the sympathomimetic amines, and they fall into two groups. They're either amphetamines or non-amphetamines, and because amphetamines are not FDA approved for weight loss, we're not going to address them here. They have a high abuse potential. So these drugs both fall under the non-amphetamine sympathomimetic amine classification. And within these groups of drugs, there are 4 approved for weight loss. However, only 2, the diethylpropion, which is generic name for the drug, and we also have phentermine, which is the generic name for the drug as well. Those are the ones that should be used. Okay, so 4 are approved, but only these 2 should be used because the other 2 have a higher potential for abuse. So how do these drugs work to promote weight loss? They also work by decreasing your appetite. They work on the central nervous system and they stimulate the CNS, suppressing your appetite by increasing the availability of norepinephrine at the receptors in the brain. The same mechanism is used and it's underlying their stimulant effects, which give them the potential for abuse. Weight loss is usually only modest, so we only want to use them for very short term, only 3 months or less. And within those 3 months, you may only lose like 8 pounds. So this is why these drugs have kind of come out of popularity, they don't produce the same effects of our newer drugs on the market. And because they are like amphetamines, they can increase alertness but also decrease fatigue. It induces nervousness and insomnia. These are some of the adverse effects. Because it can also interfere with sleep, the drug should be administered no later than 4 p.m. because it will exacerbate insomnia. After drug withdrawal, fatigue and depression may replace that CNS stimulation. So you have a very high, and then you take away the drug, and then you go low with fatigue and depression, much like amphetamines. They also have an effect on your periphery, not just your CNS. Peripheral effects are limited to tachycardia, anginal pain or anginal pain, hypertension. So although they're not central nervous system effects, they are still pretty concerning. And accordingly, then, these drugs should be used in caution with patients that have any type of cardiovascular disease. And what I would say is that, to me, it's not worth it if you're only going to lose 8 pounds and you can only use them for 3 months. That risk for me as a provider, I just wouldn't take that risk. The risk for abuse is lower than with amphetamines. However, there is still some some risk for abuse. Both of these drugs are also scheduled under Schedule 4 of the CSA, and the other two drugs, which we aren't really talking about, the other two drugs that have been approved but we shouldn't use, they're actually under Schedule 3. Tolerance is common, and we see tolerance after the use of 6 to 12 weeks, and if it develops, then the response is to discontinue the drug, not to increase the drug. And if you're wondering what those other two drugs are called, you can find them in the book: bensphetamine and phendimetrazine. And these are the ones that are also approved, but Schedule 3 with a higher risk profile for abuse. We're finally talking now about glucagon-like peptide 1 agonists. These are probably the most common and most popular drugs right now. The book uses liraglutide as its prototype, and so will we, but I will just be talking about GLP-1 agonists globally, just as a whole. And we know that they were first manufactured for the management of type 2 diabetes. So in addition to weight loss management, it also enhances glycemic control. It's going to increase insulin secretion and decrease glucagon secretion. But most people right now, they are using it for the weight loss benefits, and it does this by increasing your patient's feeling of fullness. It kind of tricks your brain into thinking you're full, or tricks your stomach actually, and it's going to lead to the patient eating less. If they feel full, they're not going to eat. There are some adverse effects to consider. There are cardiovascular effects actually. 1 in 20 people will develop tachycardia, up to about 20 beats a minute above their baseline. But more commonly, you're going to get the GI effects: nausea, vomiting, either constipation or diarrhea. You're going to hear complaints about dyspepsia and abdominal discomfort. If you are giving this medication to a patient who is diabetic and they have other anti-diabetic drugs, you want to really pay attention because you may cause a hypoglycemic event. It's less common for patients that don't have diabetes or they are not on anti-diabetic drugs. Because you're giving this as a sub-Q injection, you also want to look for local site reactions like pruritus and redness. There are several uncommon effects, but we do want to talk about them too because they can cause more damage than the more common effects. And those include acute pancreatitis, gallbladder disease, and renal impairment. The renal impairment usually is associated with dehydration, that's secondary to nausea, vomiting, and diarrhea. The contraindications for a patient for a GLP-1 is if they have known thyroid cancer or a family history of medullary thyroid carcinoma, or multiple endocrine neoplasia syndrome, and this is called MENS. Let me say it again. Multiple endocrine neoplasia syndrome type 2. And this is because this drug has caused thyroid cancer in rodent studies. Taking a closer look now at GLP-1s, there are some special monitoring needs based on the adverse effects that we talked about earlier. You do want to get a baseline A1C, lipid panel, and renal function test. You also want to make sure that the patient understands that it's not a pill. They have to be able to give themselves a sub-Q injection, or their family member has to give it to them. So they need to be educated appropriately and return that demonstration. And A1C is going to be followed up on every 6 months if they're stable, more often if needed, or you're initially starting. I usually start with a 3-month period for most drugs anyways. Periodic monitoring of their triglycerides, and you're looking for any signs and symptoms of cholecystitis, cholelithiasis, pancreatitis, depression, and suicidal thoughts as well. Your high-risk patients are anyone that is pregnant, if they have a family member, or they personally have a history of thyroid cancers or neoplasias, and if they have a history of pancreatitis, renal impairment, or gallbladder disease, they are not a candidate for this medication as well. It's a very expensive drug, although it's not on the controlled drug list under the CSA, which makes it a winner, but also it has typically more weight loss within a 12-month period than the other drugs, and you can use it for longer. But again, this is not a drug that you want to use long-term anyways. You do want to use this in conjunction with the management of lifestyle changes, good diet, and exercise. Something that you probably notice is that most patients, although this has an average of 12 pounds, most patients that you're seeing on social media and in the news, maybe even someone they probably have lost more than the 12 pounds. Also to note, that's not listed here in this chapter per se, but I do want you to realize that the dosing for someone using it for diabetic glycemic control is different than the dosing for weight loss management. There are some patient-centered care concerns across the lifespan. You do want to know for children, the serotonergic drugs and the GLP-1s and combination drugs are not approved. Orlistat is not approved for children under 12. Okay, remember, Orlistat is the one that works directly on the GI, doesn't let you absorb fat, but you have to be 12 or older. Pregnant women, it's never recommended that you are on any type of weight loss regimen while you're pregnant. You're trying to grow the baby. This is something I don't even consider with my pregnant patients. We also know that diethylpropionate is a teratogen, and so we definitely wouldn't want to prescribe that. However, it's one of the drugs that you don't get much benefit anyways, right? You can't use it for that long. You're not going to lose that much weight. For all the drugs that we talked about today, with a breastfeeding woman, it is not recommended. Now, for older adults, it gets tricky because many times as you get older, you have more comorbidities. So if they already have renal impairment, I probably wouldn't consider most of these drugs. For patients with moderate renal impairment, the combination drug should be limited to only 1 tablet, and you're going to watch their creatinine clearance. You also want to think about any patient with hepatic impairment, that these combination drugs are also limited to 1 tablet. And I wouldn't prescribe actually the combination of fructaramine and topiramate together for anyone with severe hepatic impairment. Do take some time to look at the black box warnings, and also spend a little bit of time looking into the combination drugs. Again, they are not as popular now as the GLP-1s because we're seeing more weight loss with those drugs. But something to just bring up here, Contrave, it was something that was very popular for a while, and that's a combination of naltrexone and bupropion. And this combination was associated and still associated with an increased risk for suicidal ideation and suicide attempts in children, adolescents, and young adults.